In this portion of the lecture, we're going to talk about a few of the more major types of visual problems, and we're also going to talk about hearing disorders as well. When we talk about cataracts, we're talking about an opacity that exists inside of the lens, and is caused by protein changes in the lens itself. It can occur in one eye or in both eyes. Obviously, this is a picture where the person doesn't have it in one eye and they do in the other. The cataract removal is the most common surgical procedure in the United States. When we look at some of the influencing factors, age is a major one, although they can be related to other factors like blunt trauma, congenital factors. We often see congenital cataracts in infants associated with other um, congenital abnormalities, or we may see it with a congenital infection. Uh, Exposure to radiation or UV light, long-term corticosteroid use, and ocular inflammation. In addition, patients with diabetes tend to develop cataracts at a much younger age. Cataracts cause a decrease in vision, and it can cause an abnormal color perception. So as you can see in this picture, this would be somebody with normal vision on the left and somebody who had a cataract on the right. So if you think about the lens being clouded over, it's not going to let the light that tells us about color intensity in as strongly as it does normally. So you would see a less intense color. You may also get glaring with lights. Most people that have cataracts will notice that most at night, that there's halos and things like that around street lights. Usually the visual decline is gradual, uh, but the rate of the development of the cataracts vary from person to person. When we look at diagnostic studies, we want to know the history and physical examination. We want to know when they started noticing a change in their vision, if there's other complaints that are associated with their vision. We want to do visual acuity measurements, and we can do that with ophthalmoscopy. They also will use the slit lamp microscope. If any of you have been into your ophthalmologist, they put your chin up real close and then they shine that light into your eye where it's like a rectangular shape that, of course, drives your retina crazy. But that's your slit lamp microscope, and they also do glare testing. The opacity is directly observable by ophthalmoscope, and obviously the slit lamp microscopy examination as well. A totally opaque lens creates the appearance of a white pupil, and you saw that in the previous picture. Some of the non-surgical therapies, there's really no non-surgical cure when it comes down to that. But often, just because they see a cataract doesn't mean that surgery needs to be done right away. I know for myself, about 3 years ago, my ophthalmologist said that she noticed a small cataract in my eye. And of course, it makes you panic when you hear that. But she says, you can walk around for years with a small cataract and it really doesn't affect your vision all that much. And I really haven't noticed a big change in my vision as far as my little cataract is concerned. Some of the things, though, that you can do is to have good diet and things like that. Visual aids like changing your eyewear prescription may help. Reading glasses may help. And for some people, they may need magnifiers. And being in increased lighting improves the vision as a whole. So we're going to follow a little EM through this section. EM is an 82-year-old female, and she's escorted by her daughter into the preoperative area for removal of cataracts in the right eye. Her daughter asks you what can be done to prevent cataracts. What should you tell her? So, although there's no way known to completely prevent cataracts, you could tell the daughter that there's some basic steps that can improve overall eye health, and that is something that can help prevent or slow down the process. Things like wearing sunglasses, avoiding unnecessary radiation, maintaining appropriate intake of antioxidants like vitamin C and E, and in general, good nutrition. And you can also use other visual enhancing techniques. One of the things that I wanted to let you know about when it comes to these vitamins, especially these antioxidants, is there was a study done through the NIH, or which is the big major government institutes of health, but within that there's the National Eye Institute, and they did a trial where they called it the Age-Related Eye Disease Study, or the AREDS. In that study, they looked at age-related macular degeneration and cataracts to evaluate if high doses of vitamin C, E, beta-carotene, and zinc had any effect on the progression of age-related macular degeneration or cataracts. And the results from the study showed that high levels of antioxidants and zinc significantly reduced the risk of age-related macular degeneration. Now, remember, the macula is in the center of the eye, and you need that to see. Well, age-related macular degeneration, that area just starts to, as the title says, degenerate. And so in increasing these antioxidants, it improved the vision of these people, and they didn't lose their vision as quickly. The same nutrients really didn't have any significant effect as far as the development or the progression of cataracts, but it definitely improved age-related macular degeneration. Now, I'm not quite sure why we aren't covering that as much, because that's one of those really major things that we see as people age, but we're not. They did another study. They called it the AREDS 2, and in that they found that when you added omega-3 fatty acids to that formulation, as well as lutein and zeaxanthin, it appeared to be safe and effective, and could be used instead of the beta-carotene. If you remember, beta-carotene is what we find in yellow vegetables like carrots and squash. So basically, if you think about it, if you have high levels of beta-carotene, you increase your risk of having a yellow tone to your skin caused by the vitamins that you're getting from the beta-carotene. So there's other ways of getting the same effect as far as preserving vision than having high beta-carotene levels. When we look at surgical therapy for cataracts, in the preoperative phase, we obviously are going to do a history and physical. Usually the patients have local anesthesia. They don't require an extensive preoperative physical assessment, but most patients with cataracts are older adults, and so they may have other medical problems that are confounding the issue, like high blood pressure or heart disease. And so definitely those need to be evaluated and make sure that those are under control before having surgery. Almost all the patients with cataracts are admitted to the surgical facility as an outpatient, and they're normally admitted a couple hours before surgery just to allow the necessary time for the different procedures, like starting their IVs and getting them ready. They'll receive dilating drops and a non-steroidal anti-inflammatory drop in their eye to reduce inflammation. One type of drug that's used for dilation is mydriatic, which is an alpha adrenergic agonist that produces pupillary dilation by contracting the iris dilator muscle. Another type of drug is a cycloplegic, which is an anticholinergic agent, and that produces paralysis of the accommodation muscles by blocking the effect of acetylcholine on the ciliary body muscles. The patient may receive preoperative anti-anxiety medications as well. I always kind of laugh about that because every time I've had these little day surgeries, I'll be sitting there and it's like these anesthesia doctors are out there to sedate you, because they'll come along and go, "Are you feeling anxious? Do you want me to give you something for it?" And it's like, "No, I'm really quite fine, thank you." But yeah, in some patients, they may need a little anti-anxiety medication. During the intraoperative phase, the cataract extraction is done intraocularly, and they'll use an operating microscope. So this upper picture is showing showing one of those operating microscopes. And the anterior capsule is open. The lens, nucleus, and cortex are removed, leaving the remaining capsular bag intact. An extracapular extraction, the surgeon removes the lens by photoemulsification, which I have some pictures about all of that. And in that case, the nucleus is fragmented by ultrasonic vibration, and then it's aspirated out. And then the remaining cortex is aspirated with an irrigation and aspiration instrument. Larger incisions require closure with sutures, whereas smaller incisions are self-healing and they may not require any closing sutures at all. It used to be that people would talk about how they could feel the sutures in their eye when they had their cataract surgeries done. And now they're using smaller and smaller incisions, so they're not having to use those sutures, and so they're having better results. At the end of the procedure, additional medications like antibiotics and corticosteroids may be administered. And then depending on the type of anesthesia, the eye may be covered with a patch or a protective shield. And if it's used, it's usually worn overnight and is removed during the first post-operative visit. So it may be there for several days that they require that. So this is a photoemulsification. It's the most common form of cataract surgery. We talked about how the ultrasonic vibrations dissolve the lens. And usually you don't need sutures with this type of procedure. The extracapular cataract extraction is used for advanced cataracts, where the entire cataract is removed. Sutures are required for it, and recovery is usually a little bit slower. The video that I posted for you was an extracapsular cataract extraction. In addition, there's not a lot in here about laser-assisted surgery, but we're starting to see more and more laser-assisted surgeries for cataracts. And this allows them to make very precise, smaller incisions. A lot of the doctors feel like it's safer than when they're using a scalpel. In addition to making the cuts in the cornea, the laser can often soften the cataract, so it's easier to take out. They can, of course, we know that they can also use it to fix other vision problems as well. A lot of times, insurance won't pay for a laser-assisted surgery. And, they'll pay for a cataract surgery, but they don't pay if it's a laser-assisted. So they'll pay the normal fee for a um, emulsification or one of the other, the extracapular version, but they won't pay the additional fee for the laser part. So sometimes there's a larger out-of-pocket fee for patients if their doctor decides to use a laser-assisted surgery. One of the things that we have to think about too is that obviously we've removed the lens. The lens is how we focus so that we can see. And almost all of our patients are going to have an intraocular lens implanted at the time of the cataract surgery. The lens of choice is a posterior chamber lens that's implanted in the capsular bag behind the iris. Usually they get antibiotics and corticosteroids after surgery. There's 3 different kinds. The one on top is called a fixed focus monofocal lens, and this type can help you see one distance well. So you can either see up close or you can see far away. And so sometimes what they do is, especially if there's a cataract in both eyes, is they'll put the lens for up close in one eye, and in the other eye they put the lens for distance. And so you might say together the person is able to have decent vision without glasses, but they have what's called monovision. And you'll often see patients that have this done kind of sitting there and squinting one eye. So it doesn't work real well for a lot of people. So they have come up with the one on the bottom left, and that's called a monofocal accommodating lens. And these actually you can see in the picture, they're sort of attached to those ciliary muscles, and they're able to stretch and also constrict, and so that you can actually get more of a normal accommodation with those lenses. And finally, this one over on the fingertip over here is called a toric lens. And a lot of people have astigmatisms of their cornea. And so the ophthalmologists have developed this toric lens that is able to fix the astigmatism that the person has. And so basically, when they're done with it, they don't need to wear glasses because the astigmatism is repaired with this lens. Postoperatively, like we said, usually it's an outpatient procedure unless some complications have occurred during the surgery. As soon as the effects of the anesthesia has worn off, the patient is usually ready to go home. Postoperative medications usually include antibiotic drops to prevent infection and corticosteroid drops to decrease the postoperative inflammatory response in the eye. The recommendations for postoperative activity restrictions and nighttime shieldings vary based on the ophthalmologist's preference. So we can't say that this is always going to be what happens, but in general, most of the ophthalmologists still want the patient to avoid exercises that increase their intraocular pressure, like bending or stooping, coughing if they can avoid it, or lifting. During each postoperative exam, the ophthalmologist will measure the patient's visual acuity, they'll check the anterior chamber depth, and they'll assess the corneal clarity and measure intraocular pressure. Even on the operative day, the patient's uncorrected visual acuity in the operative eye may be very good. It's not unusual, or if it's reduced immediately after surgery, and it doesn't, you would almost expect that to happen. The postoperative eye drops will gradually be reduced in frequency, and then they're finally discontinued when the eye has completely healed. The multifocal intraocular lens, we talked a little bit about that. It can correct for both far and near vision, and regardless of the type, the patient still may need to have glasses or contact lenses to have perfect vision. A lot of people have this idea of, oh, I'm going to get this new lens and I won't need glasses anymore. But depending on what your problem was to start out with, you may still need to have glasses. So when we look at nursing management, we're going to check visual acuity. This picture obviously is blurred in the middle, and this is what we would see with somebody who has moderate to severe cataracts, and often they don't do cataract surgery until it gets this bad. So we want to assess the patient's distance and near visual acuity. If they're going to have surgery, we especially want to note the visual acuity in their unoperated eye. With this information, you want to determine how visually compromised that patient may be while that operative eye is healing. So in other words, if you don't have a whole lot of vision in, say they're doing the right eye, if you don't have a lot of vision in the left eye, then you're going to need more help at home during the healing process. We want to make sure that they understand the disease process, so we want to assess that and their comfort and ability to comply with the postoperative treatment. You know, some may look at you and go, what do you mean I can't bend over? You know, and pick up anything heavy. I take care of my toddler grandchild. Well, they're going to have to find another way of dealing with that. So suggesting ways that they might be able to still be able to do the things that they're used to doing is going to be really important. But we want to make sure that they are going to follow post-op directions. As far as diagnosis and planning goes, addressing self-care deficits, any anxiety. Anxiety is usually related to a lack of knowledge about the surgical and postoperative experience. Although it's not unusual to have a certain amount of anxiety when someone's going to have surgery. We want to make sure that they're making informed decisions as far as their therapeutic options are concerned, and so that we can minimize their anxiety. So EM seems quite upset. She has many questions that indicate she has unwarranted concerns and worries about surgery. What should you say? Well, obviously we need to use therapeutic communication and ask her about her concerns. And we want to help her distinguish between her worries and concerns that need interventions, but also be sensitive to issues associated with older adults, like the fear of loss of independence, loss of control in their lives, and diminished self-esteem. We want to answer questions about the procedure from the beginning to the end and provide written material for her to refer back to. You know, most of the time when people are given instructions, they only remember about 20% of what they're told. So providing that written information will allow them to go, well, they said something about this, but I don't remember what. Instead of sitting there not knowing, they have a resource to find out. And be sure that her daughter understands the information that you're providing, and encourage her to maintain frequent contact with her mother at that time. As far as planning goes, we want to look at postoperative goals like understanding and complying with the postoperative therapy, maintaining a level of comfort, and remaining free of infection and other complications. So one of the things that we have to be concerned about is if someone does not have good visual acuity um, and they're on their own, are they going to be capable of giving themselves the drops that they need to get? And so we would probably want them to show us how they're going to instill the drops in their eyes, just to make sure that they're capable of doing that. As far as health promotion goes, we talked earlier about wearing sunglasses on bright days, avoiding unnecessary radiation, making sure there's adequate antioxidant vitamins, and ensuring good nutrition. As far as during the acute care period, teach them about the disease process and the treatment options and administer medications, and inform those with a patch that they will not have depth perception. That stereo, I've forgotten how it ends, but stereotactic vision that we have comes from both eyes and the input that both of our eyes give us. So when we take that away, we may lose some of our depth perception. So they should know that that may be an issue. We also want to make sure that as we're talking to them, that they understand that the loss of depth perception could make them more prone to falls or for other injuries. And if they have significant impairment in their unoperated eye, they may need more assistance until their operated eye has healed and has been unpatched. Some patients may require 1 to 2 weeks for the visual acuity in the operated eye to reach an adequate level for most of their visual needs. And so they may need some special assistance until that's improved. The other big thing is to teach them the signs and symptoms of infection so that they know when to call the doctor and have that taken care of. So EM's vision is equally impaired in both eyes. She's scheduled in a few weeks for cataract removal in her left eye. So what should you tell the patient and her daughter to expect post-operatively? Well, what we should tell them is they shouldn't feel very much pain, if any. She'll be temporarily unable to see out of the eye that's received surgery. She'll need to use eye drops, and she may need assistance because she has impaired acuity in the other eye. As far as ambulatory care, we want to, most of these patients are only at the surgical facility for a few hours, and then them and their caregiver are given written and verbal instructions before discharge, and these should be include information about post-operative eye care, activity restrictions, medications, and follow-up schedules and signs and symptoms of possible complications. The patient's caregiver should be included in the instruction because some patients may have difficulty with self-care activities if their vision is poor in the unoperated eye. We want to provide opportunity for them to perform a return demonstration of any necessary self-care activities like putting in eye drops. We want to teach them about what to expect post-operatively with their visual acuity and instruct the family to modify activities in environment like removing area rugs, prepare frozen meals, and provide audiobooks for diversion since they won't be able to read. So EM tells you she lives in an apartment and will return there post-op. If the patient is visited only once a day at her home, what may be of concern? Well, we're always going to be concerned about fall risks, but with her, one of the concerns is going to be whether or not she can give herself her medications, if she needs any help with her ADLs. until her usable vision returns. When we look at the evaluation, the expected outcomes will be that they have improved vision, that they have the ability to care for themselves, that they have minimal to no pain, and any pain that they have should be able to be taken care of with over-the-counter pain medications, and that they have an optimistic expectations as far as their outcomes. One of the things that we want to make sure that we do, though, is have them know when to call their ophthalmologist. And that would be if they notice a loss of vision, the pain doesn't get better with over-the-counter pain relievers, the eye is very red, or they see flashes of lights or floaters. When we think about the gerontologic considerations, older adults are more prone to have cataracts, so we need to be sensitive to their self-esteem. When your vision is impaired, even temporarily, they experience a loss of independence and a lack of control over their lives. And often there is can be a significant change in their self-perception. And if you think about it, this is a time of life where many things are being lost, the abilities to do things. And so there's always that fear that this won't go away and things won't get better. So older people need emotional support and encouragement, as well as specific suggestions to allow for a maximum level of independent function. We want to ensure that older people that have had cataract surgery, that their safety issues and everything can be done, and their surgery itself can be accomplished safely and comfortably with minimal sedation. Because remember, again, a lot of these patients have comorbidities that can affect them if they're put out too deep. EM's daughter tells you she lives an hour away and works full-time. So what nursing management is essential for her during the postoperative period? Well, you want to ensure that the patient and the daughter understand the importance of complying with the postoperative therapy. They should take measures to maintain the patient's level of comfort. They need to ensure that the patient is free of infection and other complications, and discuss options for EM as far as transportation for her follow-up appointments. Moving on to glaucoma. Glaucoma is a group of disorders that are characterized by increased intraocular pressure, or IOP, and the consequences that are associated from that pressure. Often it can result in optic nerve atrophy and peripheral vision field loss. So what I was just mentioning before, this is what somebody would see that had glaucoma. They would start out with early glaucoma with they call it tunnel vision. So it's dark on the peripheral areas, and gradually it just becomes smaller. Their vision becomes smaller and smaller as far as what they can see. It's the second leading cause of blindness in the U.S. It's the leading cause of blindness in African Americans. Many are unaware, and the incidence increases with age. It is preventable, and there is a genetic component to it. So SH is a 66-year-old female, and she comes to your community health screening and tells you she's having some trouble seeing. She says it runs in the family. What can you teach the patient about the importance of seeing an ophthalmologist? Well, you want to teach her that there are some very serious eye problems that run in families. And you want to ask her more about her symptoms and explain that early detection and treatment is often very important to prevent further loss of sight and the complications that go along with it. So when we look at glaucoma, there's two forms of it. One is called primary open angle glaucoma, or POAG. It's the most common type of glaucoma, and it results from the outflow of the aqueous humor being decreased as it goes through the trabecular meshwork. Basically, what's happening is the meshwork gets clogged up, not unlike a kitchen sink or any other sink could get clogged up. And so then that results in the fluid not being able to flow and circulate in a normal manner. This can result in damage to the optic nerve as the pressure builds up in the eye. With primary angle closure glaucoma, so let's go back one. Here we had primary open angle glaucoma. Now we have primary angle closure glaucoma. The angle closure causes a decrease in the flow of the aqueous humor. It's caused by a reduction in the aqueous humor that results from the angle closing. So if you look at where the trabecular mesh is and how the fluid flows through it, in the angle closure glaucoma, you can see that this little angle where the fluid would flow through, that it actually is closed, or at least mostly closed. And so instead of the fluid being able to flow up by the lens, above the lens, it just flows right back into the back of the eye. So usually it's caused by the lens bulging forward as a result of the aging process. And the angle closure may also occur as a result of pupil dilation in the patient that has anatomically narrow angles. An acute attack may be precipitated by situations in which the pupil remains in a partially dilated state for a long period of time, so that it causes an acute and significant rise in intraocular pressure. This can occur because of drug-induced mydriasis, emotional excitement, or darkness. The drug-induced mydriasis may occur not only from topical ophthalmic preparations, but also from many systemic medications, both prescription and over-the-counter drugs. So you want to check drug records and documentation before administering medications to patients that have angle closure glaucoma, and instruct the patient not to take any mydriatic producing medications. So what we need to know is that the big difference between them is that POAG develops slowly. Often there's no symptoms, and it's unnoticed until the peripheral vision is severely compromised. Eventually, the patient with untreated glaucoma has tunnel vision, in which only the small center of their visual field can be seen, and all the peripheral vision is gone. However, with the acute angle closure glaucoma, it comes on suddenly. And usually they'll report they have excruciating pain in or around their eyes, nausea, vomiting. They start seeing colored halos around lights, blurred vision, and ocular redness. So if you remember with the first part of this lecture for chapter 20, I told you that one picture looked like it was glaucoma, that possibly that there was a cataract as well, But glaucoma often looks like that as well. And in that picture, there was a lot of redness of the eye. So SH confines that actually she's had tunnel vision and very bad shooting pains in her eyes lately. So how much should you be concerned and why? Well, you should be very concerned about the possibility of acute angle closure glaucoma and its potential effects, because early diagnosis and treatment can help these patients to not lose their vision. So when we look at the clinical manifestations of glaucoma, we see the intraocular pressure is elevated. Remember, normal IOP is between 10 to 21. And in open angle glaucoma, we see pressures going up in the ranges of 22 to 32 millimeters of mercury. And in acute angle closure glaucoma, it's more than 50 millimeters of mercury. So I'm going to apologize for my weird slide. When I transfer things over from PowerPoint to Keynote to do these videos, sometimes it doesn't maintain its look that I started out with, but missed that one, but most of the time I managed to catch them. When we look at diagnostic studies, they may be completed with a slit lamp microscopy, peripheral and central vision test, and ophthalmoloscopy. Big word. In the open angle glaucoma, the slit lamp microscopy reveals a normal angle. In the angle closure, the examiner may note a markedly narrow or flat anterior chamber angle, an edematous cornea, a fixed and moderately dilated pupil, and a ciliary injection. And we may do measures of peripheral and central vision that provide additional diagnostic information. And we also may do, especially in acute angle glaucoma, central vision acuity may be reduced if the patient has corneal edema and the visual fields may be markedly decreased. So when we look at the retina with the ophthalmoscope, what we may see is what they call cupping of the optic disc. So if you look at the top picture, you can almost see like an edge of a cup going around the optic disc. And it usually is one of the first signs of chronic open angle glaucoma. Also, in the bottom, we have the optic disc becomes wider and deeper and paler. So in comparison of A to B, that bottom one is much more pale appearing. Light gray or white, which is visible with direct or indirect ophthalmoloscopy. So you insist that SH sees an ophthalmologist, but she insists that she sees just fine if she turns her head a lot. How should you handle her reluctance to seek treatment? Well, we need to listen to them. There's usually some reason why they don't want to go to the doctor. Maybe they can't afford it. You want to gather more information about her symptoms. You want to inquire about her knowledge of her symptoms and what they might mean. You want to try to find out more about her resources for healthcare treatment and coverage. Most people know that ophthalmology is kind of an expensive thing, and a lot of time insurance doesn't cover it. And so that may be her issues, that this is out of pocket and she doesn't have the money to pay for it. As far as interprofessional care is concerned, with chronic open angle glaucoma, drug therapy is what's used first. And the therapy is to keep the intraocular pressure low enough to prevent the patient from developing optic nerve damage. And if the drug therapy doesn't work, they may do the argon laser trabeculoplasty. and it stimulates scarring and contractions of the trabecular meshwork that allows that fluid to go through easier. Or in some cases, they may actually do a trabeculotomy, which would remove that trabecular area so that the fluid could flow easier. But in general, it's done when the medical management, in other words, the drug therapy or the laser surgery, has been unsuccessful. I wanted to talk to you guys a little bit about the drugs that are used for glaucoma. I would recommend getting this slide blown up or taking your PowerPoint and making it a full page so that you can read this better. Sorry that my tables don't match up exactly perfect. They came from different sources. But basically it talks here about the types of the drug classifications that these meds fall under, and then examples of the medications that fall under that drug classification. Also, as you know, we need to know what side effects may be associated with it. So if you look on this, it's listed by drug classification and what kinds of side effects, both systemic and locally, we may have to worry about. Finally, I found this other little page where it talks about how to remember the drugs that are used in glaucoma. This says in 5 minutes times. It would take me more than 5 minutes, but basically it looks at these are the drugs that decrease the aqueous production versus the ones that increase the aqueous outflow, which would mean that it helps for the flow to be more normal. So I would recommend really making a nice big page of this for your study. With acute angle closure glaucoma, miotics are used. And again, I've put up this little thing that talks about the mechanism of action, the local side effects, and systemic effects. Usually there's very few systemic effects associated with miotics, but it definitely is something that can happen. Miotics tend to be used before the oral or hyperosmotic agents, which are things like mannitol and other medications that are used to lower the IOP. They may do laser peripheral iridotomy or surgical iridotomy, and what that does, if it's necessary, it prevents subsequent episodes by opening up that angle that had acutely closed. And so that allows the aqueous humor to flow through that new opening in the iris and into the normal outflow channels. In some cases, they may do it to both eyes, just as preventative, a just-in-case situation, because often they could experience an acute attack in the other eye as well, and we just haven't seen the signs of that happening yet. As far as nursing assessment, we want to assess their ability to understand and comply with treatment. We want to make sure that their psychological reaction to sight-threatening disorder is addressed. We want to also assess the family's reaction and see if that is a support system that the patient has, and whether or not there is a caregiver that can help that person if they need help. As far as expected goals, the goals would be that there's no progression of visual impairment, that there's an understanding of the disease process and the rationale for therapy, and that the patient is going to be compliant with all aspects of therapy, and that there's no post-operative complications if we've had to do surgery. As far as health promotion, with this, we want to teach patient and families the risk of glaucoma, and also note that that risk increases with age. So in other words, if you have a family that you know that glaucoma runs in the family, the chances are you are going to have glaucoma. And so planning ahead and thinking about making sure that you're getting your eyes checked regularly and assessed for glaucoma is important. You want to make sure that they are getting ophthalmologic examinations. Basically, the current recommendations is every 2 to 4 years for persons between the ages of 4 and 64, and every 1 to 2 years for persons ages 65 or older. African Americans at every age category should have an examinations more often because of the increased incidence and the more aggressive course of glaucoma in this population. As far as implementation, we want to administer medications to lower the intraocular pressure. For surgical patients, we want to provide post-op instructions and relieve any discomfort. As far as ambulatory care goes, we want to remind their patients to follow their therapy, teach them about their disease process, the treatment options and their rationales, and information about the purpose, the frequency, and the techniques for administering the anti-glaucoma drugs. So, SH tells you she is all alone, no husband or children, and her best friend and neighbor died last year. If she's diagnosed with glaucoma, what can you tell her about possible treatments? So, if she's unsure about having surgery because of lack of support, she can pursue non-surgical options, and it may slow the progression of the disease. But the surgical treatments are available, and they're effective, and most can be done on an outpatient basis with a fairly quick recovery time. There are support services available to help people with their health problems in ADL that have been affected by the treatment for them, and so we would want to make sure that they knew about those. As far as the expected outcomes, there should be no further loss of vision. There should be compliance with the recommended therapy, and there should be safe functioning in their home environments. They should also have pain relief from disease and from surgery. And when we're talking about disease, we're talking about disease of the eye. As far as the gerontologic considerations, there's a lot of caution that needs to be used with these potential drug interactions, especially with systemic illnesses and their treatments. We want to teach that occluding the puncta will limit systemic absorption of the glaucoma medications. So as you learned in giving up the eye meds, after you drop it in their eye, you should be putting some pressure on the inner canthus, the puncta, and that will prevent the medication from draining down into the nose and being more systemically absorbed. And so especially if patients are using beta adrenergic blocking agents, it can cause them to have bradycardia. They may, they're contraindicated if the person has bradycardia because it can cause it. It's also contraindicated for patients that have heart block, greater than a first-degree heart block. Obviously, we don't want to give it to people with cardiogenic shock or any overt cardiac failure. The non-cardio selective beta adrenergic blocker are contraindicated in a patient with chronic obstructive pulmonary disease and asthma because it can cause constriction of the airways. And the hyperosmolar agents can precipitate heart failure and pulmonary edema because they're pulling all the fluid into the circulating system. And if your heart is already having difficulty dealing with what's already there, then that can just make that much worse. And then the older person on high dose aspirin therapy, maybe for rheumatoid arthritis, should not take the carbonic anhydrase inhibitors. The alpha adrenergic agonists can cause tachycardia and hypertension, which also could be a problem for an older patient, but could be a problem for somebody who's on high blood pressure meds. We also want to teach the older patient to make sure that they're giving their eye drops correctly, because a lot of people just drop them in their eyes and they don't do all of the steps in proper eye med instructions. All right, so as you talk more with the SH, she tells you more about her problems that include a history of hypertension, type 2 diabetes, and hyperlipidemia. Why do these problems put her at greater risk for glaucoma? And the biggest thing that's there is that some of her medications may actually potentiate the effects of the treatment for her possible glaucoma. In other words, these medications that she's taking combined with her other meds for the glaucoma actually may make all of them work even more. So the question, and I put this answer on your notes section of the pages. The nurse instructs a patient with primary open glaucoma, angle glaucoma, about the disorder. Which of the following statements, if made by the nurse, is most appropriate? The retinal nerve is damaged by an abnormal increase in the production of the aqueous humor. The aqueous humor cannot drain from the eye, causing pressure damage to the optic nerve. C. As the lens enlarges with aging, it pushes the iris forward, covering the outflow channels of the eye. Or D. The lens blocks the pupillary opening, preventing the flow of aqueous humor into the anterior chamber. In this case, the answer is B. And the rationale is that in primary open-angle glaucoma, the outflow of the aqueous humor is decreased in the trabecular meshwork. The drainage channels become clogged and damage to the optic nerve can then result. So now we're going to talk about hearing loss and deafness. So when we look at hearing loss and deafness, there's two things that we look at, whether it's a conductive loss or whether it's a sensorineural loss. And the conductive loss occurs in the outer and middle ear, and it impairs the sound being conducted from the outer to the inner ear. And it's caused by conditions interfering with air conduction, like otitis media with effusion, impacted cerumen, foreign bodies, middle ear disease, or otosclerosis. Sensorineural hearing loss is caused by an impairment of the inner ear or the vestibular cochlear nerve, which is your cranial nerve 8. And that results in the inability to understand speech. Some of the causes of that include congenital and hereditary factors, noise trauma, aging, Meniere's disease, and ototoxicity. With conductive hearing loss, often the patient speaks softly because they can hear their own voice, which is conducted by the bone. And so it seems really, really loud, even though they're speaking very softly. So think about yourself when you have headphones on or you have your earbuds in. If you talk, it seems like you're talking really, really loud, but your friends or whoever you're talking to may go, "What?" because you're talking so softly. You also, in this case, you'd want to identify and treat the cause if possible. So in other words, if they have otitis media, which is an ear infection, You'd want to treat the ear infection because that would take care of the hearing loss. And in some cases, there's no way to correct the cause, and so a hearing aid may help if the loss is greater than 40 to 50 decibels. So audiologists can consider anything above a 20 decibel loss to be mild hearing loss. But as far as getting a hearing aid, they usually do not get a hearing aid until they're at 40 decibel loss or more. A sensorineural hearing loss results in the ability to hear sounds, and it's usually caused by impairment of the inner ear, the vestibular cochlear nerve, and the ability to hear high-pitched sounds, including consonants, diminishes. So if you talk really high-pitched, a person with sensorineural loss won't be able to hear you. But if you talk in a lower voice, they may be able to hear. The sounds become muffled, and the person has difficulty understanding. An audiogram demonstrates loss in decibel levels of the 4,000 hertz range and eventually in the 2,000 hertz range. A hearing aid may help some patients, but it only makes sounds and speech louder, not clearer. And so often people will say, well, why can't you just give him a hearing aid? Well, all you're doing is making this noise that they can't understand louder in their ear. And so it doesn't really help them to hear better. So sensorineural hearing loss is often caused by an impairment of the inner ear, damage to the cranial nerve 8, congenital or hereditary factors, or noise trauma, or aging. We call that presbycusis, or Meniere's disease. Meniere's disease makes you kind of dizzy all the time, just in general, because it's affecting the vestibular system. Some of the ototoxic drugs that may cause a sensorineural hearing loss include aspirin, NSAIDs, antibiotics, specifically things like aminoglycosides, which would be like gentamicin, erythromycin and vancomycin, loop diuretics, and chemotherapy drugs like vincristine and cisplatin. We also have something known as a mixed hearing loss, where there may actually be a combination of both conductive and sensorineural causes. And so very careful evaluation is needed if corrective surgery for conductive loss is planned, because the sensorineural component of the hearing loss will still be there. Central hearing loss involves the inability to interpret sounds, including speech, due to a problem in the brain or the central nervous system. So it's important to do a careful history because usually it's a familial or genetic cause, and so you want to refer them to a qualified hearing and speech services if that's indicated. Functional hearing loss can sometimes be caused by emotional or psychological factors. The patient doesn't seem to hear or respond to pure tone subjective hearing tests, but there's no physical reason for the hearing loss that can be identified. Those patients need to have psychological counseling. In some cases, some people get what's known as a sudden hearing loss, where they're suddenly deaf. It's unexplained, rapid loss of hearing. It usually affects just one ear, and it is considered a medical emergency. Just to kind of look at what the classifications of hearing loss are based on the amount of decibel loss. If you're at 0 to 15, that's considered normal hearing. 16 to 25 decibel loss is a slight hearing loss. Mild is 26 to 40. You kind of get that idea. So obviously you should know what normal hearing range is in decibels, and you should have a general idea of what's mild, moderate, and severe impairment. So SR is a 79-year-old widower, and you meet at the family practice clinic where you work. You notice that he speaks unusually loud and seems to misunderstand what you say quite frequently. So what should you do? You could try to use some communication aids to ensure they're getting the complete and accurate information. You can do a focus assessment on their current complaints, but also ask questions about his hearing deficits. Be sensitive to the patient because they may not even realize that they're not hearing. And you could suggest that they have an evaluation by an audiologist and provide the information, why you think this is important, and listen to his questions and concerns. Usually what we see with hearing loss, the early signs often go unnoticed by the patient. Usually they're being pressured by others to get some help because they're frequently asking others to speak up. They're answering questions inappropriately. They're not responding when looking at the speaker. They're straining to hear. They're trying to read lips, and they're increasing sensitive to slight increases in noise levels. Often the patient is unaware of minimal losses, and it's usually the family and friends who get tired of repeating or talking loudly are the first ones to notice. Pressure is usually exerted by significant others to have their hearing checked. The clinical manifestations also is because deafness is known as an unseen handicap, because it's not until conversation is initiated with a deaf person that you realize that they can't hear. We want to make sure that there's validation that this person is understanding any health teaching that we're doing. We want to make sure that we have descriptive visual aids. What makes this really bad is if you have somebody who has visual problems on top of it, or somebody who is unable to read. That makes this even worse. We want to make sure that if you have a hearing impaired individual that uses sign language to communicate, that the Americans with Disabilities Act requires that an interpreter is provided, and that should, like every other language, this is not to be somebody in the family. This is somebody outside of the family that has no personal involvement with the person. We want to look at other clinical manifestations like ineffective communication and interaction. It can be both frustrating for the patient and the caregiver because at times people start feeling like he's ignoring me on purpose. The loss of clarity of speech in the patient with sensorineural hearing loss is very frustrating to those that are listening because they can't hear themselves talk, so their words often will come out very garbled. They often will start to withdraw. They may become suspicious. They may have loss of self-esteem, and they may become insecure. And so it's important that these patients have these things addressed and that their hearing is assessed. One form of hearing loss that's very disturbing to a lot of people is tinnitus, and it's a perception of noise without an actual source of sound. It's often referred to as a ringing in the ear or head noise. It's sometimes the first sign of hearing loss, especially in older persons. It can be soft or loud, high-pitched or low-pitched. I think we've all had some ringing in our ears at one time or another, a little buzzing type noise. Both are caused by inner ear nerve damage, and the main difference between tinnitus and hearing loss is the extent of the damage, because in tinnitus, sound can still be heard. Although it's the most common cause of tinnitus, it can also be a side effect of medications. More than 200 drugs are known to cause tinnitus. One of the major causes is a damage of the hairs inside the cochlea. And so I just wanted to point that out when we're talking about damage in the cochlea. So when we look at health promotion, we want people to minimize their environmental noise exposure. Noise is the most preventable cause of hearing loss, and hearing loss caused by noise is not reversible. You want to avoid continued exposure to noise louder than 70 decibels as much as possible. So if you think about it, the sudden severe loud noise is known as acoustical trauma. Chronic exposure to loud noise causes noise-induced hearing loss. Both can damage hearing. Sensorineural hearing loss as a result of increased and prolonged environment noise, such as amplified sound, is occurring in young adults at an increasing rate. And that's mostly because of amplified music in iPods, telephones, and this whole putting earphones on and earbuds in, and so amplified music should not exceed 50% of maximum volume. Ear protection needs to be worn when firing a gun or during other recreational pursuits with high noise levels. A lot of rock stars, especially these older ones, have hearing loss because when they were younger, they didn't use any protective ear sound protection. And so now that they're getting older, they really are having this sensorineural loss. Sting is one of those that has sensorineural loss. He really can't hear himself anymore. Hearing conservation at work. They can do noise exposure analysis, and OSHA requires ear protection for workers in environments where the noise levels are consistently higher than 85 decibels. And periodic audiometric screenings are part of the health maintenance policies of industry. So these workers need to be wearing hearing protection, and they should be getting periodic hearing screening. Usually it's once a year, and education about preserving their hearing. Immunization. For all of the things that we've talked about how immunizations can't cause problems, but fetal damage can be caused by viruses, and those viruses can cause deafness as a result of fetal damage and malformations affecting the ears. So we want to promote childhood and adult immunizations, including measles, mumps, and rubella immunization. Rubella infection during the first 8 weeks of pregnancy is associated with a high incidence of congenital rubella syndrome, which causes sensorineural deafness. Women of childbearing age should be tested for antibodies to these viral diseases. Women should avoid pregnancy for at least 3 months after being immunized, and immunizations must be delayed if a woman is pregnant because it can cause this same sensorineural deafness. And women who are susceptible to rubella can be vaccinated safely during the postpartum period. So after talking a bit to SR, he confides that he worked in a factory that was very loud. He retired 10 years ago. He tripped on the steps and hit his head last night. And so what types of hearing loss could he be experiencing? Well, acoustical trauma caused by chronic exposure to loud sounds over 70 decibels can destroy hair cells in the organ of corti. Presbycusis is just hearing loss associated with aging, so he could be having that. Hearing loss from impacted wax is very, very common in older adults. Loss of hearing from an infection, and he could have hearing loss from damage to the ear or a possible head injury resulting in nerve damage. I have to tell you that in the same way that Dr. Pimple Popper and everything is, there's people that are into this whole impacted earwax, and you would be surprised at the size of some of the earwax balls that they pull out of people's ears. You can continue your assessment, and you realize that SR was recently placed on antibiotics for a UTI. Why is a complete review of medications especially important in this case? Well, for one thing, if they have an acute or chronic condition, they could be on diuretics. And we know already that loop diuretics increase the risk of deafness. Also, you know that some antibiotics are ototoxic, so you'd want to know what those are. And then you want to know what kind of over-the-counter medicines he's taking, like aspirin or NSAIDs. And those can increase hearing loss or tinnitus, and it may even contributed to his fall that he had recently. So you would want to stop ototoxic medications that could result in a reversal of his hearing disturbances. Of course, he needs to talk with his doctor about those. So as far as health promotion, we want to avoid ototoxic substances, especially drugs, ototoxic substances like industrial chemicals, toluene, carbon disulfide, and mercury. And monitoring is really important. And we may need to discontinue the drugs if there's any sign of ototoxicity. I have a friend that is deaf, and he's deaf because of an ototoxic drug. As far as interprofessional management, there's a number of assistive devices and techniques like hearing aids. These are fit by a hearing aid specialist or an audiologist. They provide amplification, sound lateralizations, and speech discrimination. They require a motivated, capable user for optimal success. And my ex-husband was an audiologist, so I guess that's why I got stuck with this one. And so I can tell you that there's some people that they have 1 or 2 problems with their hearing aids and they stop wearing them. And other people, they know that it's going to make their life better. And so they keep coming back and working with the hearing aid specialist or the audiologist until they're able to tweak that hearing aid just perfectly for them. Basically, there's all different sizes and types of hearing aids. Some are better for some people than others. If you have difficulty with managing small objects, the tiny little ones that you can't hardly see probably is not a good thing for you. But on the other hand, your hearing problem may determine what type of hearing aid you end up with. So it's one of the things that we have to make sure of is that a person's hearing aids are cared for properly. That includes regular cleaning. Usually they change the batteries once a week, and they're stored in a dry, cool place with the battery removed. Um, we say that, but there's actually hearing aids now that are rechargeable. And so when they're put away in their case and it's plugged in, the hearing aid is being recharged and the batteries are not changed on those. We have to make sure as nurses that we handle hearing aids properly for our hospitalized patients. Hearing aids are expensive. Um, Normally, a person does not get just one hearing aid. It has to do with the stereotactic um, system of hearing. You need good hearing in both ears to be able to function normally. And so hearing aids will run starting at around $4,000 for a set of hearing aids, and they go up in cost from that. So when a hearing aid gets lost, we aren't talking about a small investment, we're talking about a huge, huge investment that has been lost for that person. Other assistive devices include speech reading, which is lip reading, and the person looks at visual cues associated with speech, and it facilitates an understanding for about 40% of spoken words. It was really interesting to see some of the things that I saw where it showed the difference in the shape of the mouth between different vowels. But things like rabbit and woman look very similar when you're looking at the mouth. And so sometimes the gestures and the facial expressions tell more about what's going on, but also is very important. You want to help the patient by using and teaching verbal and nonverbal communications, and your book has a table in it that talks a little bit more about that. Sign language is used as a form of communication for people with profound hearing impairment. It involves gestures and facial features like eyebrow motion and lip-mouth movements. American Sign Language is used in the United States and in English-speaking parts of Canada. So what you have to understand is sign language is not the same in every language. So a lot of people have this idea that everyone in the world who is deaf is speaking American Sign Language. Well, that's not true. And American Sign Language doesn't really have sentence structure the way we're used to having it. And so it is its own language. And so when you have patients in the hospital, especially if they're from other countries, they may not be able to talk to an interpreter for American Sign Language because there is some fairly major differences between the different types of sign language. Also, there's implantable hearing devices or aids. Some are fully implantable and nothing externally visible, and others are partially implantable because they have an external component that's worn behind or in the ear. And these are for patients that cannot or will not use traditional hearing aids or do not want to go with a cochlear implant. They amplify sounds and they transmit the sound vibrations through the ear. Cochlear implants, and I gave you a couple of videos about this. It's a system that consists of an external microphone placed behind the ear, a speech processor, and a transmitter implanted under the skin that changes sounds into electrical impulses, and a group of electrodes that are placed within the cochlea, and that stimulates the auditory nerves in the ear. They send information that covers an entire range of sound frequencies. They're for severe to profound sensorineural hearing loss in one or both ears. Ideal candidates became deaf after acquiring speech and language. It's much easier for them to interpret the information that's being broadcast to their neurosystem. For patients with conductive and mixed hearing loss, the cochlear Baha system may be surgically implanted, and that system works through direct bone conduction, and it integrates with the skull bone over time. It requires either one. It requires extensive training and rehab with speech pathologists to receive the maximum benefit from these implants. The cochlear implant provides sound. It improves lip reading ability. It enables monitoring of their own speech volume, and it decreases feelings of isolation. In addition, there may be some things that are just plain amplification devices. It means it just makes things louder. You see those sometimes on late night TV where it says, you know, does your husband always play the TV loud? And it shows him putting in this little thing in his ear that looks like a hearing aid, and it allows him to have the volume down on the TV. That's just an amplification device. There may be alerting systems like a light that flashes when the doorbell rings, or a light somehow on the phone that tells somebody. Of course, a lot of us on our cell phones have vibration on, so that maybe we don't have the sound up, but we get the vibration that tells us that we're getting a phone call. Somebody who's deaf may have something similar. There's texting systems that have been used for years and years and years with telephones, and closed captions is available on most television stations. In addition, there's specially trained dogs that alert their owners to specific sounds in the environment that increases their safety and independence. And so those things are out there. So our little guy here, what are some of the verbal aids that you could use to communicate with a hearing impaired person? Well, speak normally and slowly. Do not over exaggerate your facial expressions. Do not over enunciate. Use simple sentences. Rephrase sentences using different words. Write names or difficult words. Don't shout. Often shouting just makes things worse because it garbles it up more for them. Speak in a normal voice directly into the better ear. What are some of the non-verbal aids you can use? You can draw attention with hand movements. You can have the speaker's face in good light. Avoid covering your mouth or face with your hands. Avoid chewing, eating, and smoking while talking. Nothing is more gross for somebody who reads lips than for you to have a mouthful of food. You want to maintain eye contact, avoid distracting environments, avoid careless expressions that the patient may misinterpret. Use touch, move closer to the better ear, and avoid light behind the speaker. So in other words, you want the light to be at your face, not behind your head, because you want them to be able to see your face. Otosclerosis is the most common cause of bilateral hearing loss in young adults. The tympanum takes on a reddish blush. They call that Schwartz sign, and it results in poor air conduction. It's treated with medications that slow bone resorption and hearing aids and surgery. Basically, the bones disintegrate for all practical purposes, the bones in the ears, and that leads to deafness. On examination, let's see, the tuning fork test and an audiogram demonstrates good bone but poor air conduction. It's treated by medications to slow the bone resorption. The first ear to be repaired is the one with the poor hearing, and the second ear is repaired after the first one heals. The procedure is usually performed under conscious sedation. And there's significant hearing improvement, usually immediate, with gradual full recovery as the fluid in the middle ear resorbs. Some of the special post-op care involves minimizing sudden movements to avoid vertigo and actions that increase the inner air pressure, like coughing, sneezing, lifting, bending, and straining, kind of the same things to avoid that we would see with cataract surgery. Presbycuspus is hearing loss associated with aging, and of course they have what we see is a decline in word recognition ability and associated psychological and communication issues. It includes loss of peripheral auditory sensitivity, a decline in word recognition ability, and those communication. Because consonants, which are high frequency sounds, are the letters by which the spoken words are recognized, the ability of the older person with presbycuspus to understand the spoken word is greatly affected. Vowels are heard, but some of the consonants fall into the high frequency range and they can't differentiate between them. It can lead to confusion and embarrassment because of the difference in what was said versus what was heard. You hear the jokes about, there's a commercial that I see periodically now where I can't remember exactly what the woman says to the husband, but he goes, "No, I don't think you're like your sister more than you." And this would be an example of presbycuspus. It's related to degenerative changes in the inner ear, and noise exposure is thought to be a common factor. Often, more than one type of presbycuspus may be present in the same person, and the prognosis for hearing depends on the cause of the loss. Often people think about, we talked a little bit about hearing aids. Sound amplification with the appropriate device is often helpful. In other situations, an audiologic rehab program may be valuable for them. The older adult is often reluctant to use a hearing aid and some of the reasons they give is the cost, how ugly it is, and insufficient knowledge about hearing aids, and amplification of competing noise. If you consider a lot of times people can't hear in a noisy environment. And so they start feeling like, well, if I have a hearing aid, it's just going to make that worse. And sometimes they have unrealistic expectations of what a hearing aid can do as well. And so if somebody has, like I was saying earlier, stiff fingers, a large joint, or a decreased sensory perception, it can make handling and doing the care for the hearing aid difficult. And so they often will give up if they're having problems with that. And some of the older adults just accept that that's part of getting older and they don't need to have anything to help them out, which is kind of a fatalistic way of looking at the world, but that's how they do. So that completes the lecture about our hearing and vision problems. If you have any questions, just give me a call or send me an email. And I usually get online about once a day to check emails to see what's going on and if any of you need help. So just let me know. I'll talk with you soon.